Okay, nursing students, future clinicians, anyone who's about to step into the whirlwind of OB clinicals this deep dive. This is absolutely for you. We're aiming to give you a kind of shortcut today.
Yeah, not just reciting facts, but really building that muscle memory for the comprehensive newborn assessment.
Exactly. Because that moment, when a new life arrives and bam, you're the one assessing if everything's okay.
Mhm.
It's intense.
It really is. So our goal here is to take all that textbook info, all the research, and boil it down into a system you can actually use. We want you to feel confident, not overwhelmed.
Right. Confident about what to look for, what needs your attention right now.
And this assessment, it's a bit different, isn't it? You're juggling that clinical urgency with, well, being gentle, protecting that crucial bonding time, supporting breastfeeding.
It's a balancing act. It kicks off with super quick checks right at birth.
Yeah.
And then it flows into the more detailed head-to-toe, the admission assessment.
Ideally, yeah, right there in the room with the parents.
And underpinning every single observation, every decision you make, there's this framework. We're calling it RAG-T.
RAG-T. It sounds maybe a bit technical, but it's basically the foundation for solid clinical thinking. It helps you move from just seeing something to actually understanding it.
Okay, let's break RAG-DT down because honestly, internalizing this now,
Yeah,
it's your safety net when things get stressful.
definitely. So R is for recognize. Is what you're seeing normal, or is it a red flag? Simple question, but critical.
Then A is analyze. Okay, why is this happening? Is it because the baby's preterm? Did mom get meds late in labor? Was there a birth complication?
You're digging for the cause. Then G, generate solutions. Based on your analysis, what's the plan? Does the baby need warming, oxygen, maybe full resuscitation?
T is take action. Do the thing you plan.
And finally, E is evaluate outcomes. Did your action work? Did the baby's heart rate come up? Did the color improve? It closes the loop.
And, sometimes you'll run through RAG-T in like seconds. A baby comes out limp, dusky.
Instantly. You recognize distress, analyze probable hypoxia, generate the idea of simulation and positioning act. It's rapid.
Which is exactly why we need to start with those absolutely critical first 5 minutes after birth.
Right. Those first moments are all about survival. Before you even think about a full head to toe, there's this immediate, focused check.
Purely focused on, does this baby need help right now? Is resuscitation needed? Our sources highlight 5 key things to check immediately.
What are they?
Okay, first, cardiorespiratory status.
Yeah.
Breathing, heart beating. Okay, that's number one.
Sense.
Second, muscle tone. Is the baby moving, flexed, or are they kind of floppy limp?
Tone tells you a lot.
Third, thermoregulation. Simple but vital, warm and dry.
Got to prevent heat loss.
Fourth, a quick eyeball estimation of gestational age. Do they look full term, maybe a bit premature?
Just a quick visual check at this stage.
And fifth, identification of any really obvious major anomalies. Anything that might need a surgeon, like stat.
Okay, so those 5 things, boom, right away.
Exactly. And if the baby seems okay after that super fast check, breathing well, good tone, pinking up, then the priority shifts.
So skin to skin, right.
Right. Get that baby onto the parent's chest. It's the best way to keep them warm, helps with bonding, gets that first feed going.
But even then, you're still watching, still observing breathing, color.
Yeah.
That continuous assessment never really stops.
Never. Now, guiding that initial check, giving us some objective numbers, is the APGAR score.
Ah, yes, the APGAR. It's that quick snapshot of how well the baby's handling the transition from, living underwater to breathing air.
Cardiorespiratory adaptation, basically.
But here's the thing everyone needs to remember, and the sources are really clear on this. APGAR is not a crystal ball.
Right. It doesn't predict long-term neurological outcomes.
Exactly. You can have a perfectly healthy baby who had a rough delivery get a lower score initially. Or a baby with underlying issues might score great at first. It's for immediate clinical decisions.
Not for fortune telling. So it's done at 1 minute after birth and again at 5 minutes.
1 and 5. And we're looking at 5 different areas, scoring each from 0 to 2. Max score is 10.
Let's quickly run through those 5 areas because sometimes it's easy to mix up what a 1 versus a 2 actually means in practice.
Good idea. The letters help you remember. A, P, G, A, R. A is appearance, which is color. P is pulse, heart rate. G is grimace, their reflex response. A is activity, muscle tone. And R is respiration, breathing effort.
Okay, so take pulse. 0 points means no heartbeat. 1 point.
That's slow. under 100 beats per minute, and that 100 BPM mark is really key clinically.
By that.
Because below 100 often triggers the start of resuscitation steps, like positive pressure ventilation.
Gotcha. And 2 points for pulse.
That's good. Over 100 beats per minute.
Okay, appearance color. 0 is all blue or pale. 1.
That's acrocyanosis. Body's pink, but the hands and feet are blue. Very common.
And 2 points means the baby's pink all over.
Right. Activity or muscle tone. 0 is limp. 1 is some flexion, maybe a bit floppy.
Kind of moving, but not vigorously.
Yeah. And 2 points is active movement, good flexion, fighting back a little.
Then respiration. 0, obviously not breathing. 1.
Slow, irregular breaths, maybe to a weak gasp.
And 2 points is good, strong cry, regular breathing.
Exactly. If you see a baby that's moving actively and crying hard, you're probably looking at scores of 2 for activity and respiration right there.
Okay, so you get the score. What does it mean for what you do? A score of 7 to 10.
That's generally good adaptation. You just continue routine care, keep observing.
4 to 6.
Moderate difficulty, might need some stimulation, maybe a little blow by oxygen near their face.
And 0 to 3.
That's severe distress. This baby needs immediate help, likely starting with positive pressure ventilation, getting the team involved.
And there's a critical rule about that 5-minute score.
Absolutely crucial. If the score at 5 minutes is 7 or less, so 7, you must keep scoring every 5 minutes.
Keep going until it's higher than 7.
Correct. Until it's consistently above 7. A persistently low score means you need to escalate care, usually move the baby to a warmer, get more support involved, follow your hospital's protocol.
But, and this is probably the most important point about APGAR, the #1 rule.
Never, ever delay necessary resuscitation just to get that 1-minute score.
If the baby needs help, help them first.
Absolutely. If you recognize that baby is apneic, limp, no heart rate, you skip right past scoring and you take action. Start resuscitation immediately. You can figure out the 1-minute score later while you're already intervening. Saving that baby's life is the only priority.
Okay, so assuming we're past that immediate crisis phase, or maybe there wasn't one, we move into the full admission assessment. And a really key insight here is context.
You nailed it. The assessment is almost meaningless without knowing the backstory, the maternal history, the pregnancy history.
I'll give you an example.
Sure. Let's say, the mother had severe preeclampsia or really high blood pressure during pregnancy. Your brain should immediately analyze the risk. Preeclampsia can affect placental function.
Leading to fetal growth restriction.
Exactly. So you anticipate possibly having a small for gestational age baby, an SGA baby. And knowing that means your plan changes. You prioritize checking blood sugar, keeping them warm, because SGA babies have less reserves.
Okay, another example. What if mom got a big dose of, say, morphine or fentanyl late in labor?
Right. Then you assess the baby, and they're kind of sleepy, breathing slow and shallow. You analyze that maybe it's CNS depression from the medication that crossed the placenta.
Which is a totally different reason for breathing issues than, say, a preemie with underdeveloped lungs.
Completely different cause, different intervention plan, or take that preterm infant, they likely lack surfactant.
That lubricant for the lungs.
Yeah, it keeps the little air sacs, the alveoli, from sticking together and collapsing. So if the history says preterm, you recognize a high risk for atelectasis, for breathing problems. You're ready for respiratory support before it becomes a crisis.
So that history is everything. And best practice says do this whole assessment where?
Ideally, right in the parents' room. It really helps with attachment, lets them see their baby, ask questions. You can teach them right there about what's normal for their baby.
Makes sense. Okay, before we even touch the baby for the full exam, safety first.
Gloves. Always wear gloves until after the baby's first bath. There's blood, amniotic fluid. It's just standard precautions, protects everyone, non-negotiable.
Got it. All right, let's get those baseline vital signs. Key tip here.
Do it when the baby is quiet. If they're screaming their head off, your respiratory rate, your heart rate, they're going to be skewed way high. Wait for a calm moment.
Makes sense. Which vital sign do we usually check first?
Respirations. Just watch the chest and belly rise and fall together. Normal rate is 30 to 60 breaths per minute.
And you have to count for.
A full minute. No shortcuts. Newborn breathing is naturally irregular. They have these little pauses. You need the full 60 seconds to get an accurate average.
And we need to know the difference between those normal little pauses and real apnea.
Absolutely. Periodic breathing, those short pauses, maybe 5-10 seconds long, totally normal. True apnea is a pause of 20 seconds or more.
Or shorter if.
Or shorter if it comes with other signs like the heart rate dropping, the baby getting pale or blue. That's apnea, and that's a serious red flag. Needs immediate attention.
Okay, after respirations.
Pulse, apical pulse. Stethoscope right over the heart, usually fourth intercostal space, mid-clavicular line. Again, count for a full minute.
Normal resting rate.
120 to 160 beats per minute when they're resting. It can shoot up to 180 if they're crying hard or drop down to maybe 100 if they're in a really deep sleep. Those variations are usually okay.
What are we listening for besides the rate?
Any persistent irregularity or any murmurs. Murmurs are common in newborns as things are closing up, but they always need to be noted and followed up.
Okay, last vital. Temperature. Where do we take it?
Axillary under the arm. It's the safest and standard method now. You tuck the thermometer tip deep into the armpit, hold the arms snugly against their side.
And the normal range is pretty narrow.
It is. 36.5 to 37.5 degrees Celsius. That's 97.7 to 99.5 Fahrenheit. You got to keep them in that zone.
What about rectal temps? We used to do those.
Generally avoided now for routine checks. There's a real risk, though small, of injuring the rectal lining, even causing a perforation, which is, life-threatening. Definitely never do a rectal temp if you suspect something like an imperforate anus.
Right, got to make sure everything's connected properly down there first. Okay, let's dig into those cardiorespiratory red flags, the signs that tell you something's wrong.
Yeah, beyond just the rate. Look for sustained tachypnea, breathing faster than 60 times a minute, especially if it continues after that first hour of transition.
And the visible signs of working hard to breathe.
Retractions. That's where you see the skin pulling in around the ribs or clavicles when they inhale. Shows they're using extra muscles.
Does it matter where the retractions are?
It does. Seeing retractions under the ribs, subcostal, or between the ribs, intercostal, suggests moderate distress. But if you see them pulling in way up high above the sternum or collarbones, suprasternal, supraclavicular, that's severe distress. They're using every muscle they can.
What else?
Nasal flaring. The nostrils flare out with each breath. It's an attempt to get more air in, decrease airway resistance.
And listening closely.
Grunting. That little sound they make when they breathe out. It's the baby trying to keep pressure in their lungs, keep those little alveoli open. It's basically creating their own peep. Grunting is always a significant sign of distress.
Any other visual signs?
Seesaw respirations, where the chest sinks in while the belly rises. It looks like a seesaw. It means they're really struggling, fatigued. It's a late, very worrying sign.
Okay, color. We mentioned acrocyanosis.
Right, the blue hands and feet, that's peripheral. Usually okay, especially early on or if they're cold.
But the one we worry about is
central cyanosis. That's blue discoloration of the core lips, tongue inside the mouth. That means the vital organs aren't getting enough oxygen. That's an emergency. Immediate action.
What about suctioning? Do we suction every baby?
No, definitely not routinely. Only if they seem to be having trouble clearing secretions on their own, lots of gurgling, choking. And if you do suction, be gentle. Bulb syringe, mouth first, then nose.
Why mouth first?
So they don't aspirate anything you loosen from the nose, but avoid deep, aggressive suctioning, especially in the back of the throat. It can cause trauma, or worse, trigger a vagal response and make their heart rate plummet. Gentle, and only when needed.
Okay, last checks in this area. Perfusion, capillary refill.
Should be quick. Press gently on the sternum or forehead, should pink back up in 3 seconds or less.
In pulses.
Check brachial, arm, and femoral groin pulses. They should feel equally strong. If the femoral pulse feels weaker or you can't find it, that's a major red flag.
What could that mean?
Could be coarctation of the aorta, a narrowing of the main artery leaving the heart. Needs urgent cardiology consult. It's a critical finding.
All right, we've got vitals, we've looked at breathing. Now let's start the actual head-to-toe map. The head itself tells us a lot.
It really does. First thing you notice is often the shape, especially after a vaginal birth. Parents often worry about molding.
That cone head look.
Exactly. It's just temporary overlapping of the skull bones to help the baby fit through the birth canal. It shows how flexible that newborn skull is.
And the key message for parents.
It's normal, and it resolves quickly, usually within a day or two, maybe up to a week. Just reassure them.
Okay, then we feel the fontanelles, the soft spots.
Right, the big diamond-shaped one on top, the anterior fontanelle, and the smaller triangular one at the back, the posterior fontanelle. They should feel soft and flat when the baby's calm and sitting up a bit.
What are we checking for specifically?
Tension. If a fontanelle feels tight and bulging, especially if it's pulsating when the baby's resting, that's concerning.
Could mean increased pressure inside the skull. ICP.
Exactly. Needs urgent investigation. On the flip side, if it feels sunken or depressed, that could be a sign of dehydration. So feeling the fontanelles gives you clues about hydration and pressure.
Okay, now the tricky part, differentiating those bumps or swellings on the scalp that can happen during birth. Kaput, versus cephalohematoma.
Ah, the classic confusion. Let's clear it up. Caput succedaneum thing. Cap, like a cap of swelling over the whole presenting part. It's just edema, soft, spongy fluid above the bone but under the scalp.
And the key feature to tell it apart.
It crosses suture lines. Because it's just fluid swelling in the scalp tissue, it's not limited by the bone plates, and it goes away fast, 12 to 48 hours usually. Benign.
Okay, so caput crosses suture lines, resolves fast. Now, cephalohematoma.
Think hematoma, it's blood. Specifically, it's bleeding underneath the periosteum, the membrane that covers the bone.
So it's trapped between the bone and its covering.
Right. And because that periosteum attaches firmly at the suture lines, the blood collection is confined by those lines. It doesn't cross. It feels firmer, has a definite edge.
And it takes longer to go away.
Much longer, weeks, sometimes even months, for that blood to be reabsorbed. And here's the clinical link you need to make. Argati time.
Okay.
You recognize the cephalohematoma. You analyze that. As that blood breaks down, it releases bilirubin. So what's the risk?
Increased risk of jaundice.
Exactly. So your generated solution and action involve monitoring that baby more closely for jaundice, maybe checking bilirubin levels sooner or more often.
Got it. Caput crosses, resolves fast, less worry. Cephalohematoma confined, resolves slow, risk of jaundice.
You got it. Okay, moving down. Skeletal check. Especially important for bigger babies or after a difficult birth like shoulder dystocia. Feel the clavicles, the collarbones.
What are we feeling for?
Any lump, swelling, or crepitus, that kind of crunchy feeling under the skin, could mean a fracture.
If we suspect a fracture, what's the management?
Usually just gentle handling. Maybe pinning the baby's sleeve to their shirt for a bit of immobilization, but rarely needs rigid splinting. The bigger concern with a clavicle fracture is potential nerve damage nearby.
The brachial plexus injury, or Erb's palsy.
Right. Stretching or damage to the nerves running from the neck down the arm. You'd recognize this by asymmetry. One arm might hang limp, maybe rotated inwards.
The waiter's tip posture.
That's the classic description. Needs immediate referral for physical therapy.
Okay, down to the hips. We're looking for.
Signs of developmental dysplasia of the hip, DDH. While the doctor or NP does the specific hip clicks and clunks maneuvers, Ortolani, Barlow, the nurse should look for clues.
Like
Unequal leg lengths. Or lay the baby on their tummy and look at the creases on their thighs and buttocks. Are they symmetrical? If the folds don't line up, that's suspicious.
And why catch this early?
Because early treatment, often with a simple Pavlik harness, works really well to keep the hip joint developing properly.
Good point. What about the spine?
Run your fingers gently down the entire length. Feel for any bumps, gaps, or unusual curves. Look closely at the base of the spine for any dimples, tufts of hair, or especially any visible sac-like protrusions.
Like a meningocele or myellomeningocele.
Exactly. If you see anything like that, your immediate action is critical. Cover it with a sterile, moist saline dressing to protect that exposed neural tissue. Keep the baby positioned to avoid pressure on it. Notify the team immediately. That's a neurosurgical emergency.
Okay, last stop in this section, the umbilical cord stump.
Check the vessels. You should see 3. 2 smaller, thicker-walled arteries and 1 larger, thinner-walled vein. Remember AVA. Artery, vein, artery.
And you document that finding. What if you only see 2 vessels?
A 2-vessel cord, usually 1 artery, 1 vein, is a potential red flag. You analyze the association. It's linked with an increased risk of hidden kidney problems or sometimes cardiac or chromosomal issues.
White kidneys.
Because developmentally, the umbilical arteries branch off arteries that also supply the kidneys. So a 2-vessel cord often triggers follow-up, like a renal ultrasound.
Good to know. Anything else about the cord?
Just note the appearance. Is it clean? Or does it have a greenish or yellowish-brown tinge? That's meconium staining.
Means the baby passed stool before birth.
Yep. Doesn't always mean problems, but it signals potential stress in utero and warrants a closer watch for respiratory issues after birth.
Okay, we've done the physical checks.
Yeah.
Now let's talk about the numbers: weight, length, head circumference. How do we make sense of this data?
These measurements are crucial clues about how the baby grew inside the uterus, their nutritional state, and even organ development.
Let's start with weight. What's a typical range for a full-term baby?
Usually somewhere between 2,500 and 4,000 grams, which is about 5.5 to 8.8 pounds.
And it's normal for them to lose a bit of weight initially, right?
Total normal.
Mm.
Most babies lose some weight in the first 3 to 5 days. It's mostly fluid shifts. Plus, they're not taking in a ton of calories until mom's milk really comes in. A loss of 5 to 7% of the birth weight is expected.
But there's a point where weight loss becomes a concern.
Absolutely. The big red flag is losing more than 10% of their birth weight. If you see that, you need to investigate immediately.
REGTE, time again.
Yep. Recognize the excessive loss. Analyze, why is the baby feeding well? Latching. Okay, enough wet diapers. Is mom's milk supply coming in? Generate solutions, maybe consult lactation, consider supplemental feeding if needed. Take action.
And the goal is to get back to birth weight by when?
Generally by about 2 weeks, 14 days of age.
Okay. What about head and chest measurements?
The head circumference is usually measured around the widest part, above the eyebrows. Normal is typically 32 to 38 centimeters, and it's usually slightly larger than the chest circumference.
How much larger?
About 1 to 2 centimeters larger. Chest is usually 30 to 36 centimeters. If the head seems way smaller than expected, that could suggest microcephaly. If it's disproportionately huge, even after accounting for molding, you might think about hydrocephalus.
And a reminder about doing these measurements.
Keep the baby warm. They're exposed when you're weighing and measuring them. Work quickly, have blankets ready, get them back skin to skin or into a warmer right away. Don't let them get cold stressed just for a measurement.
Critical point. Now, all this data feeds into assessing gestational age, right? Sometimes the dates aren't certain.
Exactly. If mom had good prenatal care with early ultrasounds, those dates are usually reliable. But if dating is uncertain or if the baby just doesn't look like the dates suggest, we use a tool like the new Ballard score, or NBS.
What does the Ballard score look at?
It's a standardized way to assess physical and neuromuscular maturity. You look at things like skin texture. Is it sticky and transparent like a preemies, or leathery and cracked like a post-term baby? Lanugo, that fine body hair, sole creases on the feet, ear cartilage firmness, arm recoil, breast tissue development, stuff like that.
So it gives you a more objective estimate of the baby's actual gestational age based on their physical development.
Right, and once you have that estimated gestational age, you plot the baby's weight and sometimes length and head circumference against that age on standard growth charts.
And then tells you if they're small, average, or large for their age.
Precisely. That's how we classify them. SGA, small for gestational age, if they're below the 10th percentile for weight. AGA, appropriate for gestational age, between the 10th and 90th percentiles. And LGA, large for gestational age, if they're above the 90th percentile.
Why is this classification so important clinically?
Because it tells you what risks to watch for. SGA babies, as we said, are prone to hypoglycemia, trouble staying warm, sometimes polycythemia.
And LGA babies,
Yeah.
often linked to moms with diabetes.
Often, yeah. They're at risk for birth injuries like shoulder dystocia or clavicle fractures because they're big. And crucially, they're also at high risk for hypoglycemia.
Why hypoglycemia if they're big?
Because if mom had high blood sugar, the baby's pancreas got used to pumping out lots of insulin to handle it. After birth, the sugar supply from mom stops, but their pancreas might still be overproducing insulin, which makes their blood sugar crash.
So SGA or LGA both need closer monitoring for blood sugar.
Absolutely. That classification directly guides your surveillance plan. It's a key part of your analysis leading to action.
Okay, we've got the big picture, the measurements. Now let's zoom in on specific body systems. This is where subtle findings can point to big issues. Let's start with the neurologic system.
Neuroassessment in a newborn is really about symmetry and reflexes. Are things working the same on both sides? Are those primitive reflexes present?
Which reflexes are key?
The big ones are the suck reflex, put a clean finger in their mouth, should be strong and rhythmic. The Moro reflex, or startle reflex, let their head drop back slightly. They should throw their arms out symmetrically in a C shape, then bring them back in.
What else?
The grasp reflex, put your finger in their palm or on the sole of their foot. They should curl their fingers or toes around it tightly. And the rooting reflex, stroke their cheek near the mouth. They should turn their head towards the touch, looking for food.
And what if these reflexes are not symmetrical? Like the Moro reflex is strong on one side but weak on the other.
That's a big red flag. You immediately analyze, could there be an injury on the weaker side? Maybe that fractured clavicle we talked about. Or a brachial plexus injury affecting the nerves. Asymmetry always warrants further investigation.
Okay, another really important neurodistinction. Telling the difference between simple jitteriness and an actual seizure.
Yes, this is a critical skill. Tremors or jitteriness are super common, often caused by low blood sugar, low calcium, maybe withdrawal if mom was on certain meds, or even just being stimulated.
How do you tell it's just tremors?
The key test. If you gently flex the jittery limb and hold it, the tremors stop.
Okay, and seizures.
Seizures in newborns can be subtle, not always the dramatic shaking you see in adults. It might be repetitive blinking, lip smacking, bicycling movements of the legs, brief pauses in breathing, apnea, or eye deviation. And critically, these movements continue even if you try to gently hold the limb still.
So if it doesn't stop with gentle restraint, think seizure.
Exactly. You recognize that pattern, analyze the possibility of seizure, notify the provider immediately, needs urgent workup glucose check, electrolytes, maybe imaging, EEG.
Sensory checks too, right? Eyes and ears.
Yep. Check the ears. Where do they sit in relation to the eyes? The top of the ear should line up roughly with the outer corner of the eye.
What if they're lower?
Low-set ears can be associated with certain genetic syndromes like Down syndrome, trisomy 21, or Edwards syndrome, trisomy 18, and often kidney problems too. It's a significant finding.
And eyes.
It's normal for newborns' eyes to cross sometimes, transient strabismus, or for their eyes to stay fixed when you turn their head, doll's eye phenomenon. Those usually resolve.
Okay, moving on. Hepatic system liver, which brings us to jaundice and glucose. Major newborn issues. Let's start with blood sugar.
Hypoglycemia, low blood sugar. The goal is generally to keep it above 40 mg/dL, sometimes 45 depending on the protocol, before feeds. We check babies at risk, SGA, LGA, preterm, infants of diabetic mothers, or any baby showing symptoms.
What are the symptoms of low blood sugar in a baby?
Can be vague jitteriness, lethargy, poor feeding, maybe a weak cry, sometimes temperature instability or even apnea or seizures if it's severe.
If you screen a baby at risk and their sugar is low, but they seem fine, otherwise no symptoms.
First step is feed them. Breast or bottle, get those calories in, that's your immediate action. Then recheck the glucose about an hour later.
And if they are symptomatic?
That's different. Symptomatic hypoglycemia usually requires IV dextrose right away to get the sugar up quickly. Can't wait for a feed to maybe work.
Got it. Now the other big liver-related issue, jaundice. Yellowing of the skin and eyes.
Caused by buildup of bilirubin. It usually becomes visible to the eye when the bilirubin level gets up to around 6 or 7 milli-GTL.
And what's the absolute must-remember rule about jaundice timing?
Jaundice appearing in the first 24 hours of life is never normal, never physiologic. It's always considered pathologic until proven otherwise.
So if you see any yellowing on day 1,
your immediate action is notify the provider and get a bilirubin level measured either via blood draw, TSB, or transcutaneous meter, TCB. Pathologic jaundice needs a fast workup for causes like blood type incompatibility, infection, etc.
physiologic jaundice, the more common type, usually shows up when?
Typically peaks around day 3 to 5 in term infants. It's due to the normal breakdown of red blood cells combined with an immature liver that can't process the bilirubin fast enough yet.
And interpreting those bilirubin numbers isn't straightforward, right?
Not at all. A level of 10 might be fine for a 4-day-old, but very concerning for a 1-day-old. You must plot the bilirubin level against the baby's age in hours, not days, on a specific risk nomogram chart. That tells you if they're in a low, intermediate, or high-risk zone for developing severe hyperbilirubinemia.
Okay, good clarification. Let's move to the gastrointestinal GI system, starting in the mouth.
Look inside. You might see little white bumps on the roof of the mouth or gums. Those are probably Epstein's pearls. Benign cysts, totally normal, disappear on their own.
I need to differentiate those from.
Thrush or oral candidiasis. That's a yeast infection. Looks like white patches, maybe on the tongue or inside the cheeks. The key difference. Thrush is often hard to wipe off, and if you do try to scrape it, the underlying tissue might be red or even bleed a little. Thrush needs antifungal treatment.
Check the suck again here.
Absolutely. Needs to be strong, rhythmic, and coordinated with swallowing and breathing. That suck, swallow, breathe pattern is vital.
What if feeding is a struggle? Constant choking, gagging, maybe turning blue during feeds.
Major red flag. You have to analyze, could there be a structural problem? Like esophageal atresia, the esophagus doesn't connect to the stomach, or a tracheoesophageal fistula, a connection between the windpipe and the esophagus. Both are surgical emergencies.
Okay, moving to the abdomen, what's normal?
Should be soft, rounded, maybe slightly sticking out. That's normal. Listen for bowel sounds.
What are the abdominal red flags?
2 big ones. A scaphoid abdomen, meaning it looks sunken or concave, scooped out, especially if the baby's also having trouble breathing. That screams diaphragmatic hernia.
where the abdominal organs are up in the chest.
Exactly, pushing on the lungs. Life-threatening emergency. The other extreme is marked distension belly is super tight, maybe shiny skin, looks really bloated, could be an obstruction, infection like NEC, also needs immediate attention.
Elimination first poop.
That first stool, meconium, is dark, tarry, sticky, should happen within the first 24, maybe 48 hours. If no stool by 48 hours, need to investigate for blockages like Hirschsprung's disease.
What about diarrhea? How can you tell?
Newborn stools change consistency a lot, but true diarrhea often has a water ring around the solid part in the diaper. That indicates high water content.
Okay, genitourinary GU system. Peeing.
First void pee is expected usually within 12-24 hours. Definitely want to know if there's been no urine output by 48 hours could signal a kidney issue.
And how do we know they're getting enough fluid later on?
By day 4, we look for at least 6 wet diapers in 24 hours. That's a good sign of adequate intake, especially for breastfeeding babies.
Genitalia check. Anything specific for males?
Check the position of the urethral opening, where the pee comes out. If it's on the underside of the penis, hypospadias, or on the upper side, epispadias, that needs urology follow-up. And critically,
For circumcision.
absolutely, that foreskin might be needed for the surgical repair later on. Don't remove it.
What about hydroslees?
That's fluid collection in the scrotum around the testes. Looks swollen, but usually painless. Very common. Typically resolves on its own within the first year. Just needs monitoring.
All right, last system. Integumentary to skin. Lots of weird and wonderful things show up on newborn skin.
So many. You need to know what's normal and benign versus what's concerning.
Let's list some common benign things.
Okay, vernix caseosa, that white, cheesy coating, especially in the folds. Protective. Lanugo, the fine, downy hair, often on shoulders and back. Melia, tiny white bumps, usually on the nose and face, just blocked oil glands.
What about rashes?
Erythema toxicum is super common. Looks kind of like flea bites, red blotches with tiny yellowish white centers. Comes and goes, moves around, totally harmless, resolves on its own. Newborn rash.
Pigmentation spots.
Mongolian spots, those bluish-gray flat patches, usually on the lower back or buttocks, especially in babies with darker skin tones. Look like buses, but aren't. Important to document so they aren't mistaken for abuse later. They fade over time. Also, nevus simplex, often called a salmon patch or stork bite. Faint pink patches, often on the eyelids, nape of the neck, or forehead. They blanch when you press them and usually fade within the first couple of years.
Okay, those are the common okay ones. What skin findings are concerning?
A nevus flammeus, or port wine stain. This is different. It's a flat, reddish-purple mark that does not blanch with pressure. It's permanent.
And why might it be concerning?
If it's large, or especially if it's on the face in the distribution of a specific cranial nerve, the trigeminal nerve, forehead, eye area, you have to analyze the risk for Sturge-Weber syndrome.
Which involves what?
Can involve abnormal blood vessels in the brain and eye, potentially leading to seizures, glaucoma, developmental delays. Needs evaluation.
Other concerning spots.
Multiple cafe au lait spots. 1 or 2 small, light brown flat spots are common. But if a baby has 6 or more spots that are larger than about half a centimeter, that significantly increases the risk for neurofibromatosis, a genetic disorder affecting nerves and skin.
Anything else? Petechiae.
Yeah, a few scattered petechiae, tiny red-purple dots from broken capillaries, might be related to the pressure of birth. But widespread petechiae, or purpura, larger purple areas, that don't blanch. That's worrying. Could signal a bleeding disorder or serious infection. Needs immediate blood work. So you've done the head-to-toe, checked all the systems, but the assessment isn't truly complete until you factor in the baby's behavior. How they act tells you just as much.
Right. Newborns cycle through different states of alertness and sleep. Understanding these helps you time your interventions.
Exactly. Right after birth, there's often that first period of reactivity. Baby's wide awake, alert, heart rate's up, breathing might be faster. This lasts maybe 30, 60 minutes, great time for that first feed.
Then they often crash.
Into a period of deep sleep. They might sleep for a few hours, really hard to wake up. It's important to let them sleep then. Trying to force a feed when they're in deep sleep is usually frustrating for everyone and ineffective.
When is the best time for interacting, feeding, doing assessments?
The quiet alert state. That's when their eyes are open, bright, looking around, but their body is relatively still. They're calm but receptive. That's your prime time for teaching parents, assessing reflexes, encouraging feeding. Cluster your care around that state if you can.
And using RGT applies to behavior too.
Absolutely. If a baby's behavior seems off, maybe they're constantly irritable, crying inconsolably with a high-pitched cry, or having really abrupt, chaotic shifts between states you need to analyze.
What could be causing that?
Could be pain, hunger, withdrawal, infection, or it could be a sign of neurological problems like increased ICP or injury. That high-pitched neurocry is particularly concerning and always warrants investigation, checking glucose, looking for infection, considering neurostatus.
Okay, so wrapping this all up for the nursing student heading into clinicals, what are the absolute anchor points to remember from this assessment?
Priority one is always cardiorespiratory status, breathing, and heart rate. And thermoregulation, keep them warm, use that axillary temp site.
Add bumps.
Know the difference. Molding is shape change. Kaput crosses suture lines, resolves fast. Cephalohematoma is confined by sutures, resolves slow, raises jaundice risk. Track those suture lines.
In the size classification.
Classify them, SGA, AGA, LGA, because that immediately tells you who needs closer monitoring for things like hypoglycemia. It guides your plan.
It really is a systematic process. And tying it all together, our final provocative thought for you.
Yeah, think beyond just the physical checks. Consider the baby's ability to habituate.
Habituate, meaning?
It's a fundamental neurological skill. It's the ability to tune out repetitive, unimportant stimuli, like the constant beeping in the nursery, the overhead lights, the feeling of the blanket.
So they can save their energy for important things.
Exactly. If a baby can't habituate, if they're constantly getting startled or overwhelmed by every little sound and sensation, they're burning massive amounts of energy, using up precious glucose, just trying to cope. It interferes with sleep, with feeding, with self-consoling.
So how we handle them, the environment we create, that's part of the assessment too.
It absolutely is. Protecting their ability to habituate, to find calm, is a form of advanced neurosupport. How quietly you move, how gently you handle them, minimizing unnecessary disturbances, and it all directly impacts their neurological organization and their ability to conserve energy to grow and thrive.
Your bedside care is neuroassessment and neuroprotection.
That's the deep dive. Now go out there and master those clinicals. You've got this.